Hello, welcome to the program. My name is Frank Lamarca. I am Professor of Neurosurgery and Orthopedics and Medical Director of Neurosurgery at Henry Ford Allegiance Health in Jackson, Michigan. A list of my disclosures. This program information is provided by the North American Center for Continuing Medical Education and an HMP Global Company, supported by an educational grant from Bioventus, LLC. The learning objectives for this program is to determine the biological selection based on procedure type and healing environment while balancing patient needs with product cost and viable bone graft options. Examine the efficacy and cost effectiveness of a premium allograft when a more potent biologic is needed. And we'll examine 24-month posterolateral fusion data from a premium allograft to determine its effectiveness against autograft and demonstration of robust fusion in non-interbody cases. So basically today I'm going to talk about spine surgery and the use of biologics in spine surgery. And first and foremost, one must understand that spine surgery is not just putting in screws. Usually the primary goal of spine surgery is to attain arthrodesis, besides obviously neurological decompression and realignment of the spinal elements when necessary. One of the most common late onset complications in spine surgery is pseudoarthrosis, adjacent segment degeneration, proximal junctional kyphosis, symptomatic sagittal imbalance, and late onset of infection. But pseudoarthrosis being one of the most common late complications. It's often associated with bone and graft quality. The risk factors such as age and gender can play a role in fusion and outcomes. Comorbidities such as diabetes as well can affect fusion rates, as well as smoking, steroid usage, and osteoporosis or bone quality. Applications for bone graft substitutes are various, and there's many different options out there in the market right now, in different forms as well as different categories. We have putties, structural allografts, autografts that can be also structural or manipulated, minimally manipulated tissues, etc. It goes on for a very long list. So what's a biologic? Well, the FDA defines a biologic as a medical product made from a variety of natural sources, be them human, animal, microorganisms, intended to treat, prevent, or diagnose a medical condition. In our case, we're looking at biologics intended to promote bone healing and fusion. And the options of those are several, as I mentioned earlier. We have allografts, which can be a cellular allograft, such as demineralized bone matrices, cellular allografts, both derived mostly from cadaveric or autograft cellular allografts, or sorry, autografts in that case. Synthetics, protein-based technologies, cell-based technologies, and aggregate technologies, which are a combination of one or two or three of the ones I listed above. Use is obviously dependent upon the situation. One has to understand the environment in which these biologics are being placed and the challenges that we have in attaining fusion. Often surgeon preference is a factor, as well as patient conditions I mentioned earlier. One needs to consider when choosing an allograft substitute or a bone graft substitute, what are the active ingredients that promote fusion? How do these ingredients affect the biology of bone healing? And what are the characteristics of the graft that we are selecting, and why are we selecting that particular graft for that particular case? And making those decisions, we have to go back to the science. In these situations, science does truly matter, and understanding what we are putting into our patients is paramount. There are multiple studies, experimental, clinical trials. Here's some examples of animal studies to ascertain if allograft products can truly create bone. And these are usually, these type of animal studies are the ones we like to see, because it can show the most powerful effects of these substitutes, because they can create bone in an environment where bone typically is not present. For example, in the subcutaneous abdominal area, in thigh muscle of the rat. But one must remember that whenever we do these type of experiments, or we are given data pertaining to these type of experiments, the in vitro and preclinical studies or animal studies are not always indicative of how these biologics are going to act in human condition, and therefore typically will not guarantee the same human clinical outcomes. And here's an example of a posterolateral rat fusion model where allograft was implanted in the posterolateral gutters of the spine of the rat, and a radiographic and micro CT evaluation of the fusion was carried out. Now, you would look at this and say, well, this is a phenomenal outcome. You see good bone grafting, some bridging of bone, but this was taken literally days after the implant. In this same model later on, even though these fusion models seem to be quite fused on CT imaging, radiographic imaging, it did not always correspond to true solid fusion when a mechanical evaluation of the fusion mass was carried out. So we have to be very critical of the data that we're given when looking at these experimental models. As I said earlier, they don't always correspond to what we would expect in reality. Now, getting back to the basics of bone healing and the science behind it, there are three main tenets of bone healing. One, first and foremost, is the osteoinductive nature of any implant, osteogenic nature, and those typically rely upon bone cells, and the osteoconductive or cell scaffolds upon which the cells build bone. And you can see, as I mentioned, those three here. Osteoconductive, where is provided by the scaffold, it facilitates bone growth. Osteoinductive is where we introduce proteins, typically growth factors, that stimulate bone growth. And then the osteogenic tenet, where the cells themselves participate in bone healing and bone formation. There's a fourth category, though, which is considered osteostimulative. This is where the material, and it doesn't necessarily have to be a biologic material itself, creates a favorable environment for bone growth, and it can indirectly stimulate and influence the cells and other tissues to produce bone growth factors, therefore bringing in cells from different areas of the body, be them mesenchymal stem cells or others, that can then help induce bone formation. But the material itself that we implant is not biologic per se, but like I said, stimulates a biologic response. There are aggregate technologies as well. These are those that combine several of the factors or the tenets mentioned earlier. Ceramic coated hardware, for example, may have an osteoconductive and osteostimulative characteristic. Structural demineralized bone matrices can be both osteoconductive and osteoinductive. And cell-based technologies, while typically osteogenic, if they are combined with, for example, allograft bone chips or other forms of scaffolds, can be also osteoconductive. The cell technologies, if they are able to produce growth proteins, can also be osteoinductive as well as osteostimulative. So here's an example in talking about osteoconductive. It's all about the scaffold. There has to be some material that the cells can bind to, that they can crawl over, basically to bridge the bone void and therefore create a fusion bridge between the two segments of bone that we are hoping to fuse. Native bone and autograft allograft products that serve as scaffolds typically have characteristics upon the surface of the material itself that is favorable for these cells to adhere and therefore crawl over and bridge, as I said earlier, the void between the two areas of bone that we wish to fuse. Natural surfaces have a roughness created by collagen and mineral layers. Examples of this are like tissue-based allografts or mineralized or demineralized bone grafts and structural DBMs. But there are also synthetic scaffolds, particularly made of titanium, PEEK, ceramics that are coated, be them mineral coated or otherwise. These ceramic surfaces are more biocompatible in many cases than metals or other types of polymers, but they have a disadvantage that the ceramics tend to be brittle and sometimes can delaminate if they're used to coat other types of scaffolds, which may have more of a structural nature to them. The osteoblasts, when they find themselves upon these scaffolds, because of the osteostimulative nature of the scaffold itself, will differentiate and increase BMP production. This is found to be more common on titanium versus PEEK. And the nanophase ceramics, those that have very small nanostructures that stimulate the cells to produce these differentiating factors, have better characteristics for adhesion, proliferation, differentiation than the micron-sized conventional substrates. So the smaller we go, the easier it is for us to communicate with the cells through the scaffolds themselves. Osteoblasts tend to differentiate more on surfaces with certain roughness. You can see that as I mentioned earlier, the smaller we go at a nano level, the more likely we're going to have a stimulative type reaction towards the cells. There are also surface roughened PEEK that have a similar type of reaction or cause a similar type of reaction in mesenchymal stem cells as would titanium themselves, but they are typically treated with some form of coating, be that titanium blasted or mineral coated of other type. Here are a couple of studies that look at some of the other effects that these implants can have, particularly PEEK. It's been found more and more that although PEEK does have a modulus elasticity much closer to the bone than titanium may have, the microstructure of a smooth PEEK surface tends to cause a fibrosis type reaction around the implant itself. And often that is secondary to a peri-implant inflammatory reaction, also caused by the PEEK itself, as we do not see that much in titanium, which seems to be much more biocompatible. These studies in particular show how some of the inflammatory markers are significantly increased around a PEEK implant as compared to smooth titanium, which is in the light blue, or a surface coated or a surface roughened titanium implant in the yellow. Because of the better understanding of the nature of these implants, these interbody spacers, and how they affect bone and create an osteostimulative or osteoinductive type environment, there's been an evolution over time. Obviously, allograft has been some of the earlier implants that we've used and are still obviously very good, but in certain instances are hard to come by and often are not easily reproducible. There's been then the introduction of carbon fibers, PEEK cages for the improved modulus elasticity, but then we saw an increase in inflammatory reaction and osteoclastic type of reactions around the PEEK implants themselves. And therefore, there's been a migration back towards the metals, particularly trabecular metals, 3D coated, 3D printed metals, which allow us to control the modulus elasticity and porosity even better. And there's been a comeback of PEEK, however, titanium coated to try and avoid those reactions towards the PEEK itself. So the dynamic process in which surface characteristics of an implant play a role in directing the bone-implant interface at a cellular level and molecular level, as I mentioned earlier, is highly dependent upon surface characteristics of the implant itself. Titanium has been shown to chemically react with bone depending on those surface characteristics. And integration, even if there's not a full span of bone across the void or through the implant itself, you can have a stable interaction between the implant itself and the bone at the level of that bone-implant interface. So the implant itself practically becomes integrated into the physiology of the bone and the fusion mass. And the nanotechnology has been shown to exploit unique advantages that direct interaction of cells on a molecular level. When we're looking at these implants at a macro level, we typically talk about porosity. As we get more towards the micro, that porosities between 700 and 500 micron seem to be the sweet spot, where typically these cells find themselves apt to migrate across the implant itself and therefore populate the implant. At a nano level, acid etching or coatings can further create a environment that stimulates the cells to produce bone morphogenic proteins or other growth proteins that then can help induce migration of other cells, reinforcing, therefore, the fusion. And it's basically at that 10 to the 6 micron, 10 to the minus 6 micron level that we see that interface between cells and the implant itself. That's the micro. And at the nano level, we actually is where the cells tend to interact and therefore can molecularly be induced to produce proteins and growth proteins. So at that nano level, we can regulate in that way an upregulation of the osteoblasts by increasing production through the cells themselves of TGF beta 1, bone morphogenic proteins 2, 4, and 7. Downregulation of the osteoclast activity also helps in increasing bone formation. And then at the later stages of bone healing and upregulation of angiogenesis using angiopoietin 1 and VEGF-A and FGF2s, these growth factors, the fibroblast growth factors in particular, will help to create then a viable bone long term. All right, so there are several studies that support the increase in bone morphogenic proteins and how the stimulative nature of surface technology can increase osteoblastic differentiation. Here is one study from 2012 showing how BMP2 levels, BMP4 levels, and BMP7 levels all react similarly with an increase when there is a titanium surface treated type of implant versus just PEEK, for example, in a bone fusion or bone healing type of experimental model. Likewise, you can see, as I mentioned earlier, TGF beta 1s and OPGs increase similarly with those same type of implants versus PEEK. Likewise, the angiogenic type factors increase more also when there is a certain level of osteostimulative environment that is regulated by the implant. And what these implants tend to do is when there's this type of communication or stimulation of the cells on the part of the implant itself, you'll have an initial and more rapid migration of osteoblasts across the void. Then once you have a population of both the implant and the arthrodeced area of bone upon which they interface, the bone will form in a bidirectional fashion, creating a much more solid and supportive bone healing process. And then long term, with the introduction of the angiogenic factors, the viability of this bone will become much more long term as it becomes a truly living bone cells integrated with the implant itself. As mentioned earlier, this is possible more so when you communicate with the cells at a nano level. Here's another example of titanium surface modifications, which can also be done in multiple layers. An initial coarse micron calcium phosphate medioblast on a titanium implant, followed by a fine micron acid etching, and as well as a submicron crystal deposition or mineral coating type technology, all can play subsequent roles in stimulating the cells at the various stages of bone formation. So when looking at implants, just to summarize that was mentioned earlier, one has to keep in mind what we are implanting. And we may want a structural characteristics in the implant, but obviously how that implant interacts with the surrounding bone is very important. There are other implants or bioactive type of implants that we can, or methods that can be used that do not necessarily utilize a biologic, but still create an osteostimulative environment for the cells to grow. Particularly certain minerals such as calcium phosphate, apatite, ceramics, and bioclast tend to stimulate osteoclast activity and therefore bone resorption and remodeling, which is also an important part of the bone healing process. And this can be dependent upon surface charges, electrical charges, and topography, as well as I mentioned earlier, porosity and solubility of those minerals. Electropotentials typically form at an injury or a surgery site, typically negative potentials, and these tend to increase the ability for or stimulate the ability for mesenchymal or osteoblastic cells to migrate towards the injury itself. And one can introduce an electrical stimulation artificially, and that often can mimic an injury type response at the site of where we want bone to grow, and therefore increase the chances of bone growth at that level. Getting back to the minerals that I mentioned earlier, 43% of bone is inorganic. Primarily, it's hydroxyapatite, which can obviously mimic the analog of a naturally occurring crystalline calcium phosphate. It's easy to synthetically manufacture. Substitutions alter the physical properties of the crystals, and smaller crystals can be absorbed faster. Obviously, you don't want them to be absorbed too quickly, because as they are absorbed, then their osteostimulative nature fades. How do they work? Well, traditional ceramics exchange ions with the surrounding environment, and therefore cause a change in electropotential. And as mentioned earlier, a negative electropotential typically mimics what occurs naturally at the site of a bone injury. That then can signal osteoblasts to build up in the area of the injury itself after the bone has been remodeled and partially reabsorbed. Bioglasses, type of silicate-based material, also contain a calcium and a phosphate that will bond with the tissue in an aqueous environment and initiate a very similar chemical reaction as would hydroxyapatite on its own, thus exchanging ions with the surrounding environment and creating an electropotential similarly with a negative. These minerals can be in various forms. They can be a powder, putty, solid structures. Often we see them in coatings placed upon the implants that I mentioned earlier, typically teak or titanium. They typically do not have a structural integrity or a mechanical integrity, so they have to be used in combination with some form of scaffold. They're available on the market as hydroxyapatites, beta tricalcium phosphates, carbonate apatite, as well as silicate substitutes, and then typical general calcium phosphates. When evaluating ceramics and mineral-based biologics, you want to understand what is the resorption profile, because if they resorb too quickly, they're not going to be beneficial, and therefore the material thickness plays a role in that. You want to understand the structural integrity, because these are typically not standalone products and need to be used either as coatings or in combination with other type of structural scaffolds, and then what effects they may have at a molecular level on the surrounding environment. Now, I mentioned earlier that typically whenever we create an injury via either surgery or naturally, there are various potentials that form at the level of the fracture site, which tend to help initiate the fracture repair process. These can be strain-generated potentials, injury-induced, and then obviously biopotentials at the growth plate. So how can we then introduce artificially the same type of electrical environment? Well, that can be done by mimicking an electronegative field around the bone tissue itself at the time of surgery or thereafter. And this can be done invasively or non-invasively. And here are some of the products that allow us to do so. You can either apply direct current. These are typically implanted stimulators with a battery. One can do an indirect type current application, which is less invasive or non-invasive at all, be that capacitive coupling and inductive coupling. Even using ultrasound or combined magnetic fields can create an electrical field that therefore mimics the injury, increasing that biopotential and therefore further stimulating cell migration. However, one needs to understand, obviously, the situation of the patient. an obese patient upon which we want to do a combined magnetic field type application is not going to have the same level of electropotentials created as compared to a direct current application. Well, let's get now into the true biologics. So non-bone cell-based technologies. These are cell-based technologies that, however, are not derived directly from bone grafting. Typically, they're mesenchymal stem cell sources, which can come from chorionic or amniotic layers of the placenta. These are isolated after birth in a non-invasive manner. Adipose tissues can be minimally manipulated, and mesenchymal stem cells can thus be isolated from them as well. The isolation process usually consists of some form of enzymatically digested tissue, from which then the mesenchymal stem cells are spun. The applications for these non-cell-based technologies are the same as for the cell-based technologies. They come in a liquid suspension form, can be applied to an osteoinductive or osteoconductive carrier. Usually it's collagen-based in many cases. They're used as a bone void filler, and the advantages are that they can be obtained abundantly, even from living donors. Sometimes it's possible to autologously harvest these cells. Disadvantages, unfortunately, is that they are mesenchymal stem cells, so they have a pluripotency and can differentiate in various lineages and not necessarily towards bone or osteoblastic lineages. So they are not inherently osteoinductive or osteoconductive unless combined with a carrier, and in certain cases they do not form osteoblasts and can actually therefore create collagen formation or other type of tissues that can inhibit fusion long term. The osteoinductive factors that we discussed earlier, the third tenet of bone growth, lies in the presence of growth factors, or the stimulation, or to stimulate the production of them. They're usually secreted by cells and platelets. They can be secreted by mesenchymal stem cells, osteoblasts, inflammatory cells, platelets, and that is in a physiologic condition. They're contained in the extracellular matrix and are embedded typically in the collagen matrix of bone. So these are factors that are secreted. They bind to collagen matrix of bone and then act as a growth factor for bone cells, or cells that are differentiating towards that lineage. They play an important role in the bone healing cascade, which is mediated by precisely cytokines and these growth factors. Many of them act in the skeleton are listed here below, basically bone morphogenic proteins. We have transforming growth factors, which help in the differentiation process of mesenchymal stem cells, fibroblast growth factors, platelet-derived growth factors, and then the angiogenic growth factors such as VEGF and the like. And here's just a list of those various growth factors that I just mentioned, the cell source from which they typically derive physiologically, the biologic effect, and their action on bone. These are the ones that basically BMPs, IGFs, and TGFs, which recruit and promote differentiation of osteoclasts and osteoblasts, so the bone cells themselves. On the other hand, the PDGFs and TGFs also have an effect on the inflammatory process of bone healing and bone resorption, while the FGFs and VEGFs are angiogenic growth factors and typically play a role in bone growth at a later stage, once the initial bone callus is formed and we have the introduction of blood itself to create a more viable bone healing outcome. And to summarize that cascade, typically whenever an injury or surgery would occur, you have the initial clot formed at the level of the fracture. The platelets tend to release TGFs, PDGFs, and the androgenic growth factors, as mentioned earlier. There's a subsequent inflammatory reaction with migration of macrophages to the area and other inflammatory cells that will secrete FGFs and PDGFs, as well as other transformative growth factors. The migration, therefore, of osteoprogenitors is enhanced by the BMPs and the ones I just mentioned earlier. There's then a proliferation of periosteum-derived cells stimulated by those growth factors to bridge the area of the injury and the fracture itself. And then proliferation and differentiation of osteoprogenitor cells to osteoblasts, thanks to the modulation of TGFs, beta, BMPs, will then permit a more mature bone formation. And at the end, obviously, we have the androgenic factors, which secure a healthy bone for future, which then will remodel typically according to the stress risers that occur upon that segment. So how can we introduce growth factors artificially to jumpstart that entire cascade, or possibly even skipping certain steps to increase the speed at which bone heals and the volume at which it will heal. We have recombinant proteins which have been produced, particularly BMP2s and BP7s, on the market today, which we can introduce in supraphysiologic doses, very high doses in certain cases. And the reason why they're introduced at those doses is because we don't exactly know what point in time in that particular circumstance they're needed. So increasing the amount of BMP present and the concentration at the level of an injury or of a surgical procedure will allow for the concentration of that BMP to be around long enough to act and allow for bone cell migration, as well as growth of the bone itself. There are also endogenous growth factors present in the extracellular matrix and physiologic levels typically. If we demineralized bone matrices contain a certain degree of growth factors as well, which would adhere to the collagen, as well as demineralized bone matrices have been found to have certain concentration of growth factors as well, but at a much lower concentration than what we would see typically in a physiologic fracture. Furthermore, those type of allografts, particularly demineralized bone matrices, need to be aseptic and sterilized. And the sterilization process, if it were to use alcohol or gamma radiation, can reduce the osteoinductivity by basically neutralizing the growth factors. So even if one were to say there's a demineralized bone matrix product rich in growth factors, the process in which it's been sterilized may actually render the effects of those growth factors. I'm not going to go over this in detail again. One can come back and look at these slides and these schematic drawings to get a better idea at a cellular level how the different growth factors attach to cell membranes, thus initiating the cascade of, as I described earlier, bone healing. Certain growth factors will increase cell migration, others cell adhesion to the scaffolds, other cell mitoses, as well as mineral deposition, etc. Now, these BMPs and all these growth factors represent, as well as all these other type of allografts which may contain growth factors, represent a cost. And on an average, those costs can vary from anywhere between $3,000, $5,000 down to $300 overall if we're just going with simple crushed cancellous bone chips. Because of that, and in particular with the efficacy of the BMP2s over time, there's been a significant increase in its utilization. In fact, from 2005 to 2018, we saw threefold almost increase in the costs with usage of BMP overall. And it is estimated that there'll be a 4.2 relative increase over time up till 2024 of these growth factors, which will furthermore affect cost. The perioperative cost of BMP2 has been studied, obviously, because it does affect the bottom line to most of the institutions where we work. Here's a study from back in 2007, actually, by Steve Glassman and others, where they looked at 102 patients over 60 years of age who required a posterolateral lumbar spine fusion. They randomized these patients to BMP with posterior allograft or a autograft iliac crest bone graft fusion mass. And they looked at the cost in these two groups over 3 months after surgery. And mind you, this is only 3 months. Most fusion prostheses can last between 1 and 2 years. The mean hospital cost for the intact submission was approximately $24,000, a little bit less for the bone graft group, because obviously they weren't using demineralized bone matrix, and autograft from the crest has minimal cost overall. There's just a slight increase in cost of the physician who is harvesting the graft. The cost associated with post-hospital rehabilitation was higher, however, in the group which underwent an iliac bone graft, and the total payer expenditure for the 3 months was relatively similar, but slightly higher for the group that underwent autograft iliac crest grafting. Mind you that in this study, only one single large BMP kit was used. If more levels were to be entertained, then the cost would escalate for the hospital due to obviously increased cost of the BMP implant. So overall, the hospital incurred an increased cost in patients treated with BMP, with the mean cost differential of approximately $3,500. It was less than the unit cost of the BMP itself. This was a $1,400 difference. It was based on cost offsets partially attributable to the fewer complications and decreased hospital length of stay, which was seen in the BMP group. Now, obviously, the less invasive nature of the surgery may have played a role in that. But again, this is only a 3-month follow-up. If we go back and look at arthrosis rates in the two groups, these numbers may change significantly. However, overall, one can argue that it's not a significant difference in cost. But there are other factors that one must keep in mind, and those related to complications that have been seen and reported with BMPs. Ectopic bone in the spinal canal with potential neurologic compromise has been identified. You can see in these slides where ectopic bone formation could be seen in the canal both from the disc space as well as in the neuroforamen, with the risk of recurrent radiculopathy at 1 to 2 years postoperatively, which may be difficult to treat. There are early complications been reported, which have then created a contraindication for the use of these BMP implants in certain situations. The BMPs have been found in certain circumstances to cause a very significant inflammatory reaction with the formation of an inflammatory seroma and in the cervical spine, which result in significant compression of the larynx and with difficulty breathing and swallowing. The inflammatory reaction can also cause an osteolytic type of reaction in the bone itself, which can then result in screw loosening or even recurrent early radiculopathy due to chemical irritation of the nerve roots themselves. We did a study back in 2006 looking at 45 patients with a male-to-female ratio of 1.5. Focal changes of bone mineral density was not present in the preoperative CT scans at all levels that were studied, but postoperatively we found a incidence of 11% of BMP-induced osteolysis, and this was concordant with other studies in the literature as well. In particular, in this study, we got pre and post-operative CT scan imaging at 1, 3, 6, and 12 months in all our patients. And this is one at 6 months where you can see a significant change in bone mineral density. Similarly, in this case, at 3 months, that same osteoclastic or inflammatory type of osteolysis can affect allograft, which also obviously has a similar is composed of bone without the cells, of course. That type of destructive effect on the implant can cause graft collapse and therefore may not be considered indicated to use in combination with allograft structural implant. There's some suggestions, studies also of other complications that could be related to BMPs. However, in all fairness, there are studies that also show that these risks are relatively low or non-existent. But one must keep in mind the report of retrograde ejaculation associated with the use of BMP and anterior lumbar interbody fusions, as well as a tendency in the literature to show that there is a higher incidence of or higher risk of cancer when using these growth proteins. Hence why they are also contraindicated when dealing with cancer patients and spine surgery. Because of the cost and the worry of some of these complications with the use of bone morphogenic proteins, there's been a swing towards cell-based technologies. The gold standard, obviously, of cell-based technology is autograft. The drawback, obviously, is the donor site morbidity, increased OR time, and truthfully, in older patients, the difficulty to attain adequate graft material. Other autologous and allogenic cell-based technologies offer alternative methods as well. Those can be used, such as devices that allow for isolation of mesenchymal stem cells through centrifugation of the patient's bone marrow, utilizing cells that derive from a cell bank, thus removed either from joints or placenta, umbilical cord. The advantages in these cases, there's no risk of disease transmission in many cases or tissue rejection, but there's a disadvantage of handling the cells and the fact that they need to be minimally manipulated. And often that occurs in the OR and it can increase OR time. Allogenic technologies, which are mesenchymal stem cell based technologies, are of two types. One is of where the product itself has viable cell bone matrices and cellular allograft. These are minimally manipulated tissues that come from donors. The mesenchymal stem cell source is typically bone. And then there are non-bone sources where these mesenchymal stem cells can be derived, as mentioned earlier, from donors' fat, chorion, amnion, or derived from standard cultures of EMA-derived cells. What's most important, however, when looking at cell technologies is to understand that you're dealing with the right type of cells. Those cells have to be viable and able to proliferate, and therefore need to be osteogenic. The right cells are obviously bone cells, osteoblasts and osteocytes, and these are the preferred cell types for any type of bone repair. Some of those cells can derive from stem cells, but not all stem cells are the same. The way we recover those cells can differ dramatically as well. The way those cells are isolated, the processes which are used to isolate them can be very different, and the way they are stored can affect their viability long term. So all of these factors can differ from one product to the other. Complete bone healing triad, as we mentioned earlier, prefers a native mesenchymal stem cell with osteoprogenitors, pre-osteoblasts. These can derive from a cancellous osteoconductive. Well, you also want some form of cancellous osteoconductive trabecular scaffold, because injecting the cells themselves into an aqueous environment without the ability for them to adhere to a scaffold obviously would result in the dispersion of the cells themselves. And often those cells need some form of osteoinductive or osteostimulative environment, which will also give them the jump start to initiate their differentiation towards osteoblasts and osteoclasts. Typically, one would prefer a cell that is harvested from healthy cadaveric donors, and most cadaveric donors aren't healthy. They're either old or they've undergone some pathologic process, but there are also many donors that are not, and I think the type of donor selection is paramount, and that goes back to the tissue banks and how they select their donors. Gross processing to remove bone marrow fraction, separate the cancellous and cortical tissue from the cells is important, and obviously the cortical tissue is processed into DBMs, and the cancellous tissue is morselized, and then the viable cells adherent to the collagen substrate is isolated. These cells typically are either fresh frozen, and they're preserved in cryoprotectant at negative 70 degrees Celsius in many cases. And then they can be used as a bone void filler when they are defrosted. And the advantages are that only allograft, that it's the only allograft that provides a complete bone triad. Many of these implants will have the cells, some form of scaffold on which to grow, and a DBM substrate, which will be the osteoinductive portion of them. And they've been on the market since the early 2000s. Disadvantages, however, that as mentioned earlier, the harvesting of these cells is dependent on the quality of the cadaveric tissue, and there is always a remote risk of infection and immunorejection, although very few reports of that have been filed. So there are two primary bone cell lineages. The osteoclast lineage, which obviously breaks bone down and allows for bone remodeling, which is also important. Those arise from the hematopoietic stem cells, hematopoietic stem cells. The osteoblast lineage, which builds bone, derives from the mesenchymal stem cell lineage. You can see how those two differentiations or cells lineages are very different. And the ones that one typically wants to attract or introduce early on in the bone healing process is the osteoblast, therefore stem cell, mesenchymal stem cell lineages. The hematopoietic stem cells derive from bone marrow. They're multipotent. They can differentiate towards macrophages as well as towards the osteoclasts. They have very clear surface markers that identify what lineage they derive from. So CD34s and CD45s typically. The osteoblast lineage, on the other hand, derive from mesenchymal stem cells, which also have a very specific cell membrane markers. They will differentiate towards the osteoprogenitor and osteoblast cells, but can also differentiate towards adipose and cartilage. Therefore, the differentiation process, the further along it is towards the osteoblast or mature osteoblast cascade, the better. And one would want, preferably, if one can attain mature pre-osteoblasts or mature osteoblasts, that would be preferred over mesenchymal stem cells themselves, because you have a much better chance of getting the osteoblast lineage cells that one really wants to implant. Once you have the, these cells are introduced, they tend to act differently depending on the environment. So the hematopoietic stem cell lineages, once they're placed in an injury or a surgical site, will induce an inflammatory type response and secrete cytokines, growth factors that then in turn may help the recruitment of other mesenchymal stem cells and hematopoietic stem cells. The mesenchymal stem cells, on the other hand, they will react to mechanical stress in particular Wolff's Law, collagen movements, as well as electropotential changes, and therefore promote osteoblast activation. I mentioned earlier, why do we prefer mature cells? And that's because it's more likely if we have more mature cells, we can attain osteoblasts versus adipose or cartilage tissue. So how do we know when those cells are heading towards the osteoblast lineage? Well, they tend to express surface markers, surface antigens. MHC2 in particular is typically seen on stem cells that are already heading towards the osteoblast differentiation. And using mixed lymphocyte reaction as well as flow cytometry, the company that produce these products can single them out or isolate them ahead of time, and therefore deliver a more mature stem cell product versus just spinning down the mesenchymal stem cells, putting them in a package altogether, and delivering them earlier. But that does limit, obviously, to a certain extent, the amount of cells that can be harvested. So that affects cost of production as well as availability of the product itself. And mesenchymal stem cells decrease with age. So the older the donors, the less likely you're going to be able to find the cells you're looking for. And here's another example of why that is important, because these same cells can differentiate in different directions, be they osteogenic, chondrogenic, muscle cells, as well as towards forming ligament and marrow stroma. One of the products on the market right now that has been concentrating on a more mature bone cell isolation is Vivigen. It does isolate cells that present a higher concentration of osteocalcin, osteopontin, and BMP2, therefore much more differentiated toward the mature cell line versus mesenchymal stem cells. They also found that these cells are capable to proliferate over time, which is also obviously the ultimate test of viability, and they will proliferate on bone chips as what we hope for. We must understand, however, that the environment in which these cells are placed is very important. In the posterolateral gutter, there's a lack of Wolff's Law and a difficulty to keep the graft in position. But on the other hand, there is a much more accessibility to vasogenic factors, vascular structures, and the cells can, in theory, live longer versus implanting these into the desert of a degenerated intervertebral disc. So in preparing the disc space in situations like this, one needs to be very attentive to the carpentry and make sure that there is some bleeding, or at least some form of way that these cells can attain vascularity. Otherwise, they will just perish within the first 15, 20 days and be unable to grow and function as we intend them to. So we're very careful in preparing those end plates. And in the case of highly sclerotic end plates, like in this case, we'll do a much more aggressive disc preparation. The outcomes tend to be quite good when those techniques are followed. The problem is, though, the cost. These implants have a similar cost to the BMP. So while we may have eliminated some of the complications associated with BMP, we haven't eliminated the problem associated with cost and value, which in today's day and age is still very important. Because of that, we start looking more so at allograft alternatives. One on the market by Bioventus is OsteoAmp. This is a differentiated allograft bone substitute. It's commonly used for lumbar and cervical procedures, but also in general orthopedics, and can be found in a sponge, fiber, granular, or putty form. What's unique about this allograft substitute is that it contains a significant concentration, because of how it is produced, of all the growth factors that we discussed earlier. So while there may not be live cells in the product itself, there's a very strong osteostimulative environment to allow for migration of cells on the scaffold itself, and therefore also to stimulate the cascade of events required to produce a healthy bone bridge. In particular, SDF1, which is found at significant concentrations in this product, will recruit the progenitor cells, which help initiate the bone healing cascade. EGF and beta-1s attract the mesenchymal stem cells, which then differentiate toward the osteoblastic chondrocyte lineage. VEGFs and PDGFs within the implant itself, as well as any of the clot that are present, will help in initiating growth of new blood vessels. And then the BMP2s within the product itself will help the mesenchymal stem cells differentiate towards osteoblasts, and they will secrete the osteoid matrix needed to create new bone. An example of a complex case, minimally invasive procedure done at multiple levels, the interbody correction, and a minimally invasive posterior approach. And you can see how at 2-year follow-up, there's a solid bone fusion. This was also confirmed by CT imaging at 1 year. For studies, one always wants to look at the literature whenever evaluating a product. The propensity scoring, looking at 12-month outcomes compared to local autologous bone, was highly favorable in the OsteoAMP cases in this particular study, with an 84% higher fusion rate compared to 61% fusion rate in autologous bone. The higher rate of fusions also correlated with a higher rate of positive outcomes. And at 24 months, likewise, similar findings were reported. So in summary, there are a multitude of biological options available on the market. We just skimmed the surface. What's most important to understand is not all biologics act in the same fashion. Science does matter. You need to understand what you're using, how this product has been obtained, and what it offers for the patient and for your surgery. And then tailor the best biological choice for each circumstance and patient characteristic. We talked about some of the pros and cons of BMPs, but in certain circumstances, those may be outweighed by the need for a more aggressive fusion. A combination of biologics sometimes may be warranted and could justify the higher cost. But overall, it's up to the surgeon to make a conscientious decision, understanding, obviously, the different categories of biologics listed here above the top of this graph, and all the characteristics that they and properties that they present, be them osteogenic, osteoinductive, osteoconductive, osteostimulative, or a combination of all of those. And based on those characteristics and the pros and cons of each option, make an educated choice for what's best for your patient and for your institution. And I thank you for your time. With that, I conclude my presentation. Thank you for joining us.